Um, Basically, I wanted to talk about, or I was asked to talk about endocrine hypertension. And from here, move that out of the way. So, from the discussion that I was putting together, you know, I thought that we were going to be talking, on more general terms, not specific endocrinology. And I see here there's an endocrinologist that joined us, so she could maybe assist us if there's anything that she wants to do in more detail. But basically, I kind of went through more of a broad-based approach that we could take to learn more and treat individuals that come through our clinics with blood pressure issues that are suspected to have maybe secondary causes that are not your run-of-the-mill primary hypertension that most of us see on a day-to-day basis. So go ahead for the next one. Um, Basically, I thought we could start off with a definition of hypertension, and it's a little contentious. There's a lot of different definitions that have come out, and the reason for that is that it's a disease process that has been shown to have a lot of morbidity and mortality, and that the aggressive lowering of blood pressure improves outcomes across the board. However, there are some differences of opinion that we can get into, and so starting off with this definition is kind of where I wanted to start. Go ahead. So, our American College of Cardiology colleagues have defined stage one hypertension in terms that we pretty much all have used to and come up through our training, being familiar with the threshold being 130 and the systolic and diastolic being pretty much the way I learned it was mainly above 89. Um, but there have been some recent trials in the past couple of years that have really shown the community here that aggressive lowering does help. So the sprint trial, of course, we're all pretty familiar with that, and then there was the Hope 3 trial that had shown that mortality benefited, as did reduced cardiovascular events with not very large changes in systolic blood pressure, with really only about 6 millimeters of mercury differences that have helped. Now, as an endocrinologist, though, I see a lot of individuals with diabetes and high blood pressure. It kind of goes part and parcel with their metabolic syndrome. So there's a different study that have been done within the trials that I pay attention to that I showed on the next slide here that involved people with diabetes. Oh, actually, this one is just trying to show everybody the differences in studies that have come out over the past couple of years and how the definitions of hypertension have varied over time. That's what really all that this slide was supposed to show us. So the next slide is the Accord trial, and that was sort of a landmark trial within the endocrinology world, showing that really individuals with diabetes did not show an overall benefit in mortality or cardiovascular event reduction when they were randomized to aggressive blood pressure lowering. And one of the reasons for that, I believe, and I'm not sure that this was really definitively shown in any subsequent studies, but basically that the individuals that have diabetes are pretty sick. Maybe they're even more sick than those that are suffering from just hypertension itself. And the benefit of lowering blood pressure to them wasn't as robust because there are other things going on that affect their morbidity and mortality that just hadn't been shown in this study. But there's a lot of evidence that has come out more recently that shows that more aggressive lowering is beneficial. So it's sort of a difference in opinion that can be shown there. So next slide. So drilling down a little bit further, and you try to talk about the prevalence of high blood pressure, and then starting to get into secondary causes, including endocrine hypertension. The one of the largest sort of ongoing surveys that occur is this NHANES study, and in the most recent sort of not most recent, but sort of the data that I was able to come across that showed a lot of differences there was about almost 30% of all individuals screened, and this is a very large screening process, were all found to have high blood pressure, and that this has been increasing in frequency and prevalence throughout the decades, especially since it was first identified or first started in the early 90s. Um, so, as we know, most hypertension is primary hypertension or essential hypertension, but the thought and the studies have shown that a good third, up to a third of individuals can have secondary hypertension. So, next slide about talking about the incidences of secondary hypertension. Most of it is renal in origin, but going further into what I wanted to talk about endocrine hypertension and when you should start to expect to see secondary hypertension. And of course, children that have high blood pressure, a lot of those individuals will have secondary hypertension. They're just not old enough to suffer from the atherosclerosis and other reasons that primary hypertension can occur. But then younger adults, people that are less than 40, a large percentage of those individuals, which we will see quite often in our adult day-to-day practice, um, have secondary hypertension too. So, like I said, a lot of the reasons for this are renal disease, contraceptive use, sleep apnea is a huge problem that causes high blood pressure in a lot of individuals. Cardiovascular disease, of course, and then, of course, excessive hormonal secretion. So, next slide. Um, so, endocrine hypertension is not as rare as was originally sort of thought, especially when I was coming up through medical school in the early 2000s. It was really one of those things that was thought to be more of a zebra, endocrine hypertension, but that's not actually true. There can be quite a few individuals with reasons for hypertension that do occur from sources that we're not really always thinking about. And one of the biggest ones is the mineralocorticoid reasons, which would be aldosterone. And then I will go through catecholamines and glucocorticoid reasons for endocrine hypertension. Thyroid hormone, I don't really touch on, but we can discuss as to reasons for that. Okay. So, when do we start to think about needing to screen for secondary causes of hypertension? Um, so, of course, I mentioned young patients, those less than 40, but then really a lot of individuals with blood pressures that are uncontrolled when they have a lot of medications on board. The thing to really think about is when you start to get above 3 antihypertensive medicines and they're really still uncontrolled with blood pressures, systolically still 150 and above, and you're sure that they're taking their medicine. Sometimes I'll ask them to start taking home measurements, and really um, one of the blood pressure measurements that I like to use the most and has been shown to have the most damage that occurs is those pressure readings that are right before bed and overnight. High blood pressure that sustains overnight. There's tons of studies out there that show that that's the most damaging time when we're supposed to be relaxing, and you can really start to see blood pressure. There's a lot of damage that can occur from that. Then, of course, if any of us come across a individual that has had a CT scan or an MRI scan or any of those kinds of things that they weren't expecting it, but you found a growth on an adrenal gland um, in the belly, that then they also have high blood pressure too. And really, they can be on no antihypertensive medicines, and they have this adrenal tumor that was identified, and they have high blood pressure. It's worth looking into that and doing an evaluation. Okay. So this is just an overview of what I wanted to talk about, but things to think about when you start to screen for secondary causes of hypertension. Um, there are probably things that everybody has seen before, and thinking about Cushing syndrome. You got your rapid weight gain and you muscle weakness, especially at the hip girdle area. So patients have difficulty sitting up from a chair, walking. They're oftentimes, I've seen them, progress over the course of several years from normal gait to then needing to walk with a cane to then being wheelchair bound. And it's one of those things that a muscle weakness is a very, very devastating but commonly seen in Cushing. And then, your pheochromocytoma, they have their spells of flushing and sweating. Hyperthyroidism is fairly not difficult, easier to pick out when they have the excessively hot and then rapid weight loss and sweatiness and the like. Go ahead. So starting off with proper history taking is essential. You really have to pay attention to what these patients are doing that could be causing hypertension that are not necessarily primary, but wouldn't lead you down a path to think about endocrinology reasons for that. So an individual salt intake, any sort of herbal preparations, teas, energy drinks, those kinds of things, all of that needs to be evaluated for cold and flu medicine, um, recreational drug use like cocaine and that kind of stuff. If there are reasons that can cause high blood pressure that you're not really evaluating for, it's a potential to miss it. Go ahead. So your review of systems is really where you can really start to drill down into endocrine reasons for hypertension, because a lot of these individuals will be symptomatic from their endocrine disease. Like I said, with Cushing's, you have this weight gain with a purple violaceous striae formation really on their abdomen, and they can develop it underneath into their axillary spaces and under the armpits. Insomnia, depression, easy bruising, like I said, the muscle weakness. Pheo is an interesting disease where you will have individuals that will present to you with short-lived spells of palpitations and sweating and flushing, um, lasting that from several minutes up to, I've read up to an hour. But the individuals that I have seen, the few that have had pheochromocytoma usually have spells that last about 5 to 10 minutes at the most. But one of the hallmark characteristics is that they do not have any symptoms in between those spells. They feel back to normal again, like there's really nothing wrong with them at all. Okay, next slide. So the 3 points that I wanted to talk about today, the major causes of endocrine hypertension that, this is not the only, and this is not by any means definitive for endocrine hypertension, but the things that we usually tend to see in our day-to-day practices, um, and should at least be in our differential when we're starting to think about reasons for it and what we can do together to evaluate for it. So one of the first ones, and the more common one to see, is primary hyperaldosteronism. A little bit less common is pheochromocytoma, and very rarely would we want to start considering. Although I test for it all the time, rarely, I don't think I've ever seen it in my testing, is Cushing syndrome. Okay, next one. So primary hyperaldosteronism, this is one of the more common ones that you will encounter in day-to-day practice from individuals when you're thinking about their high blood pressure. And it's actually, it can approach the vast majority of the reasons for endocrine hypertension. Up to 23% of individuals can have hyperaldosteronism as a reason for their pressure readings. So you have your typical triad of low potassium, high blood pressure, and a metabolic alkalosis. But that being said, the vast majority, 2/3 of individuals, don't really even have the low potassium, which you would expect to see in this population. Okay, go ahead. So of course, you have your screening criteria where you think about going down the pathway where they have resistant hypertension. They also have this hypokalemia. They have a family history of early onset high blood pressure. Maybe that you're seeing individuals that have had a stroke at a young age with no other really reasons why, except for maybe their blood pressure is high. And then, of course, like I mentioned before, any adrenal incidental finding of a mass growing, and they have hypertension, not necessarily on any medicines at all. Okay, next slide. So aldosterone, it's a adrenal-based hormone. It controls blood pressure through your sodium and water balance. And as you recalled, the kidney is primarily responsible for sodium reabsorption and wasting. And we use medicines to help that process along all the time, like Lasix and the like. But aldosterone will trigger the distal convoluted tubule in the cells that are responsible for sodium reabsorption to reabsorb sodium. Whenever you have sodium crossing a space in any biological process, water will follow that. So you get volume expansion within the blood vessel, and that's what causes the higher blood pressures that occur through aldosterone. Now, anything that involves that potassium transport system will involve sodium transport system will involve potassium as well. So with aldosterone, it'll waste potassium, it'll hold on to sodium. And that all occurs via the mineralocorticoid receptor, like I had mentioned just a little bit before. Okay, next slide. This slide is this is pulled from another sort of discussion, and it's not really anything that I wanted to highlight except that mineralocorticoid aldosterone activation occurs throughout the body. But where I wanted to focus on with endocrine hypertension is mainly in the blood vessel. So you'll have your hypertension that occurs through endothelial dysfunction, of course, but then the volume expansion too. All right, go ahead. So this one is kind of walking us through where I had kind of described it before, where you involve the renin, angiotensin, aldosterone system, and you have the kidney sensors will detect sodium deficit. This is a natural physiologic process that they will increase renin and increase angiotensinogen. That gets converted, of course, and then we go down the pathway where angiotensin 2 is a strong activator of aldosterone and mechanisms that I described before. So this is just to remind everybody and as an overview of why we have aldosterone and why it's existing in our body in the first place. Okay, next slide. So I wanted to take a step back and talk about screening and diagnosis. Endocrine diseases are less common, and hormone disease is one of those disease processes that is it's sort of a process where you have to be very sure of your diagnosis before you want to work along the pathway of treatment. And the reason for that is that hormone disease varies, and it can fluctuate throughout the day. It can fluctuate minute to minute for some hormones, and it can be difficult to pin down true disease when you're just doing a blood test. So to review kind of the back to college courses, statistics courses, and the like, screening tests are really sensitive and they're designed to be that way, but there can be a higher false positive rate because of that. So you want to do follow-up testing after you screen somebody for a disease and do a diagnostic test. Not always will you, especially in endocrinology, will you jump straight to diagnostic testing or making diagnoses based upon single lab results because of the variability and a lot of the interplay that hormones have with different natural processes that our body experiences on a day-to-day basis. So, so you try to maximize both your sensitivity and your specificity to really arrive at a true diagnosis. I just wanted to take a step back and remind everybody of that. Okay, next slide. So primary hyperaldosteronism, if you're really suspecting that, and the individual that you're talking to, you've gone through a robust H&P, and really everything is pointing towards there being a secondary cause of their blood pressure elevation, and you want to evaluate for hyperaldosteronism as a possible cause. You want to evaluate for two different things, although one has a little bit more weight than the other. So plasma aldosterone and then their renin activity. Okay, next slide. One of the reasons why I mentioned that one weighs more than the other is that aldosterone is a lot more of a straightforward measurement, plasma renin activity is complicated. And the reason that it's complicated is you have to take a patient's specimen and then you have to aliquot it out and mix it in with a standardized sort of per that lab um, um, reactions that will occur within the test tube, and that requires conversion of, like I mentioned before, angiotensinogen to angiotensin, and that's not a standard process. That will vary between lab to lab, and that can kind of give you pause and cause for concern as to, are you really measuring true renin activity? And it makes it a little bit more difficult to come up with this ratio that all of us learn is sort of the way to diagnose, or at least to screen for primary hyperaldo. So next slide. So there is a direct renin concentration test that you can do. Unfortunately, though, this is not as preferred because there are a lot of interfering substances that can make it difficult to accurately track the renin activity. Um, Endogenous, highly estrogen states like the luteal phase of the menstrual cycle, oral contraceptive use, those kinds of things, and maybe in a male patient that wouldn't be as much of a cause for concern, but still, it's not something that you can recommend as a broad-based. This can be applicable to everybody. You really kind of have to know what you're looking at before you run these tests. Okay, next slide. So, and of course, aldosterone has its issues as well. Low potassium has a very strong potential to reduce aldosterone concentration, and that's all part of the typical endocrine feedback loop. But you will recall that a lot of patients with primary hyperaldo will have low potassium. Not all of them, but the majority of them will have um, signs of, or at least history of, low potassium in their lab testing. So it gives you cause for concern that even with measuring these two hormone levels, you really have to take a lot of time to think about, do they really have this? Is it because of other processes? Do I need to fix the one process to really accurately diagnose the next? And potassium is a major complication within all of that. Okay, next slide. So plasma aldosterone and then the renin activity ratio is a great screening test, but it's not a perfect test. It's a good place to start. And the reasons mentioned, of course, the renin activity is not a standardized test. There can be interfering medications that the patient is on. Most of the time they are on them. You have the ratio greater than 30 is a good place to start, but then you have to really look at the plasma aldosterone level, because if the aldosterone is low, remember this is a test of hyperaldosteronism. So if your aldosterone level is low, but your ratio is high, that's not likely to be primary hyperaldo. There could be interfering substances there. There could be a low renin hypertension and the like. And then, varied levels of where their aldosterone levels are um, can change the test. But when you have the ratio that's greater than 30 and a aldosterone that's greater than 20, some sources would state greater than 15, the sensitivity and specificity is pretty high, good enough that you could say, wow, this is a really positive screening test and I need to go on to the next steps. Okay, next slide. All right, so thinking about interfering medications, there are a lot of them, and most of your patients will be on these when you're starting to screen for primary aldo as a reason for their hypertension. So you have to be very cautious. ACE inhibitors, of course, those all involve the renin angiotensin system. So if you're taking them and they're decreasing, you're blocking the renin effects that can cause false changes to your testing. Some patients will be started on medicine called spironolactone. There's another one called eplerenone. Those medicines will directly inhibit the aldosterone system. They're great blood pressure medicines, especially in this disease state, but you're really not going to get good results. And so beta blockers, calcium channel blockers, NSAIDs, clonidine, Lasix, all of them will do that. Now, that kind of presents a quandary of what you should do and how you should screen these people when they're on all these medicines. Really, primary hyperaldosteronism, when it's enough to make the diagnosis, it doesn't really hide. It's not going to be all that subtle. you can keep most of these patients, and then there's the morbidity of taking them off these medicines to properly screen, um, and the worry that you're going to cause a hypertensive crisis if you take them off these medicines to try to screen people. Really, I don't, and I wouldn't recommend stopping the vast majority of these medicines. Really, the one that I do stop and I do ask people to discontinue is the spironolactone. That's the one that's really going to change your test results and cause there to be unreliable testing when you're looking into this disease. So I either try to increase other medicines, or temporarily allow them to have a little bit higher blood pressure so that I can stop the spironolactone for about 4 to 6 weeks to really allow it to wash out, and then and then start my screening process. Okay, next slide. So I did a brief one on aldosteronism. That is by far not the only way, or not the end of screening, but I thought that this talk would be directed towards mainly primary care and those that would be screening for this in the first place. Of course, if you detect a positive screen, you should refer, and I would refer to an endocrinologist, as they would be the expert on this disease process, and so in primary hyperaldo, treatment is preferably surgical. You would want to identify either the hyperplastic adrenal nodule, or the nodule, or the hyperplastic adrenal gland that could be the source of the hyperaldosterone state, because there's a lot of more morbidity with that disease. And yes, you can put them on medication and sort of pat yourself on the back and have a good job done that you've cured their high blood pressure. But at the same time, it's not a cure. It's really just putting medication on top of something that could be cured with surgery. So it's worthwhile to really consider that the high blood pressure, yes, you can mitigate it with spironolactone, but you really want to, for the patient's benefit, especially if they're young, if they're in their 40s and 50s and even 60s, that maybe surgery, for all of its downsides with infection, bleeding, and the like, is worthwhile to do. That risk is worthwhile because the benefit is going to be so robust. You could potentially get rid of 90+% of their medications by sending them off to have further evaluation and then possible surgery to do that. So that is primary hyperaldo, and we can talk about that more if we have questions. And so for the next one is pheochromocytoma. This one will scare a lot of patients when you talk about it and evaluate that. It is not as common of a occurrence, but it does have very severe symptoms that patients will experience. So um, this one on the left here, I pulled off the internet. I think it looks like an MRI, and you have if you can look at it on the patient's right, right above that kidney that you can see there, there's a little tiny adrenal gland that you can just make out on the right side. But then on the left side there, on the patient's left, you'll see that above that kidney, there's a very, very large tumor. And pheochromocytoma is one of those tumors that doesn't hide either. It looks large, it looks scary, and they will always sort of be apparent when you find it. Okay, next slide. So there can be a wide variety of clinical features. You can have very little to no symptoms at all to dramatic life-threatening manifestations that these patients are experiencing. You have your typical triad of a pounding headache, profuse sweating, palpitations that can occur lasting several minutes. And it states in literature that it can happen for up to an hour. I've never seen anybody tell me that they had symptoms that long or read about that before, but that can happen. It completely resolves in between episodes, though. So if you have somebody that comes across and tells you that it's continuous, that's not pheo. That's not going to really be the case. Okay, next slide. So, of course, you have your screening tests that you want to do if you identify somebody that might have this. Now, the adrenal incidental finding, that tumor, like I talked about for primary hyperaldo, that also deserves to be screened for pheochromocytoma. Like I said, that will have some individuals with very minor to no symptoms at all, and you wouldn't know it that they have a pheo unless you screen for it. Now, individuals that come to you with those typical signs and symptoms and you want to start screening for it, you need to do that with a screen of metanephrines and catecholamines. But there are issues with that screen, just like I mentioned for hyperaldosteronism. There are issues with screening for this one too. These are fight or flight hormones. They're highly sensitive to stress. So stress in an individual that braved traffic to get to your clinic that morning or to the lab that day, it can make a difference if the person is seated or lying down when their blood is drawn. The blood draw itself, the actual physical stress of venipuncture into the bloodstream, that can cause elevations in metanephrines. It's not a lot, but it can be there. And you're doing sensitive testing here, so you have to be specific. Okay, next one. Because of all of those issues with plasma, I like to do urinary metanephrines. It has a higher sensitivity and a higher specificity. It is a little bit more technically difficult for patients. They have to take a urine sample jug home. It needs to be kept cool. They need to do it for a full 24 hours. And then you have to think about the medications that they're on too while they're doing this, stopping them for a proper amount of time before they even start the screen. Okay, next slide. So, so there are a lot of medications that will interfere with this. And I saw this or just this week where I had an individual that came to me with elevated catecholamines. Their dopamine level was high, their norepinephrine level was high. And the physician that referred this individual to me was kind of gearing this patient up for pheochromocytoma as the reason for their disease. And it's tough because I have to talk you down away from that, and I have to think about interfering meds. So the first spot that you always check when you come across elevations in these hormones, or if an individual has a need for screening, is to think about what meds they're on. There's a lot of false elevations. Tricyclic antidepressants are notorious for that. Things like amitriptyline, Elavil, antipsychotics, buspirone, Tylenol. If a patient is taking cold medicine, labetalol, all that kind of stuff can really interfere with your screening tests and really make it difficult to identify. The thing about pheo that I mentioned before is that they really don't hide. You're looking for triple the elevations, sometimes double, but up to triple the elevations above the reference range in these individuals to really have a strong suspicion that the pheochromocytoma is real. When you start to see, you know, fair to, small elevations in their hormone levels, really do a deep screen into seeing where their medicines are. This individual that I saw earlier this week was on amitriptyline and their dopamine level was high. And I was able to kind of instruct and teach about where that medicine and how it will work and why it increases these hormones inside of their bloodstream and the need to stop the medicine and then retest. Okay, next slide. So the last one to go through, it's pretty rare, but it is something that everybody should keep on their differential, because if you can diagnose it, you can really save a person's life, is Cushing syndrome. It has hypertension associated. The vast majority of individuals will have high blood pressure when they have cortisol excess. This one is the one where they'll have high blood pressure all day long, throughout the day, nighttime. They have their home blood pressure cuff reading. It's still in the 180s, even though they're on all these blood pressure medicines, even at nighttime. That consistent and sustained high blood pressure. Okay, next slide. Of course, and I apologize for the stock photos here, but this is the thing that you want to think about. And this is not everybody that has Cushing syndrome, but this is the slam dunk diagnosis that you can make based upon how they look. You have the fat pads, the striae, the abdominal obesity with thin, sort of spindly arms that are very paper thin type of a skin where they bruise easily. All the kind of stuff that would make you think about cortisol being the reason for how they look, their symptoms, and their high blood pressure. Okay, next slide. It's rare. It's very rare. There's about a 1 per million patient years. So a 1 in a million diagnosis, that's Cushing's. It takes an endocrinologist a lot of years to pick up one. And most of the time it would take a referral center too, a large catchment area, more than a million patients, coming into to this hospital system to really even see a handful of these individuals. So really most of the studies that talk about Cushing's, most of the people that write about it, they're at large referral centers, and they see studies of maybe 10 to 15, and that's where they're doing all their research on those individuals. So this is something that you want to keep in your differential, but it's got to be at the back. If you rush into a diagnosis of Cushing's, more often than not, you're wrong. So most of what we see is iatrogenic or causes of Cushing sort of syndrome-esque people, even though it's not real, but it's something that we do as physicians to patients where we give them lots of steroids for a long time. They'll look and act like those people that we see with the long and spindly arms, the pendulous abdomen, the striae, the hypertension. It's because they're on prednisone or the like, and they've been on it for years, and maybe they need to be on it, but that's the reason why it's not a Cushing's, it's not a true Cushing's diagnosis. Okay, next slide. So of course, in any endocrine test, you can't just use one test. You have to screen with robust screening, and AM cortisol readings are not good to screen for cortisol excess. You have to use a dynamic test. And one of the best ones to use, especially, and I keep going back to it, that adrenal incidental tumor that you find, one of the best tests to screen for that is a dexamethasone suppression test. And this test is pretty straightforward, and it can be done in a primary care setting where basically you prescribe a 1 milligram tablet of dexamethasone to a patient. It's one tablet. You don't need to give them any more. You tell them to take that tablet at 11 p.m. or as close to midnight as you can. Have them go to sleep like normal. They need to go to the lab the very next morning. They should not eat. They should just go straight to the lab and get the blood drawn. I would not be thinking that the test was done correctly if they got the labs drawn after 9 a.m. So really, you got to do the test first thing in the morning. 7 to 8 a.m. is the best way to do it. They have to have taken the medicine the night before. And I have some patients that go and they take the medicine, they wait 3 days, and then they go and get their blood drawn, and it's just not going to work. So you got to do it the next morning. You're looking for a test, a cortisol level that's high. So you don't want them to suppress. And if they are suppressed, the suppressed level would be less than 1.9, 1.8. Okay, next slide. So those are those 3 points that I wanted to go through. There are other reasons for endocrine hypertension. Some of them are pretty rare. All of these are really rare, but they can cause high blood pressure. Really, it's going to be pretty difficult even for an endocrinologist to evaluate for these kinds of things, but they can and do happen. A lot of these are familial issues, and the reason that I mention them is they can happen, so there's something to know. They'll happen in the adrenal steroidogenesis sort of cascade, and there'll be enzyme deficiencies that will lead to an overabundance of certain hormones. One of the biggest ones is this DOC, it's deoxycorticosteroid, and that will cause a lot of high blood pressure for these people. And then, of course, Little syndrome. I found one Little syndrome here in the last 5 years that I've been working here in Martinsburg, and it looks like primary hyperaldo for all intents and purposes, but it's not. And the and the way to differentiate them is with aldosterone. And you can give this individual one medicine, amiloride, and their symptoms dissipate, they melt away, and their quality of life improves dramatically. So Little is one of those things that you really want to look into when you're screening for aldosteronism, and it's a simple plasma test that you can do to differentiate the two. Okay, next slide. This is the last slide that I wanted to go through, and really there are other reasons that you can look into when you're really evaluating for hyperaldosteronism, of course, you have your high aldosterone level with a low renin level. That's classic. But if you find individuals that have high renin levels, really you kind of put that aside and you don't really think about really endocrine causes of that anymore. And then there are the states that mimic it, like Little's licorice ingestion. That will inhibit one of the enzymes that converts cortisol into cortisone. Cortisone is the inactivated form of cortisol, and our bodies need that. If we have just the natural production of cortisol in our day-to-day lives, if you don't metabolize that away, it will accumulate, and you'll get this hypertension aspect that looks like high cortisol levels. It looks like Cushing's on screening, but they don't have the typical Cushing's body habitus. And you do a good history, and you find that this person is addicted to black licorice, and that will inhibit the enzyme that will expedite the conversion of cortisol to cortisone. It's something interesting to think about, and you can talk to patients about that if you think that's the case. So that's kind of what I wanted to go through today. That was my last slide. I know that it's very broad, and this isn't anything that I can really go through in high detail in 30 minutes, but I thought that this would be a good way to address for individuals that see this on a day-to-day basis, and when to think about it, how to really think about it, who to think about it in, and then when to refer after you've done your initial workup.
Thank you so much, Dr. Field. That was a really interesting didactic, and I would say it was pretty detailed given the fact that you said it's hard to go in detail just an hour, but you did such a wonderful job. So we really appreciate you doing that. Thank you.
You're welcome.
I know we have some more folks who hopped on here throughout the session. So did anyone want to unmute and maybe ask a question or just chime in? Feel free to comment on anything throughout the didactic.
Thank you, Dr. Phil. It was really a nice presentation. At the primary care level, the thing which I struggle with is I have to make notes to remind myself, otherwise I will keep forgetting. I mean, from your discussion, one of the things I learned is that I just cannot rely on the renin-aldosterone ratio.
Yes.
I have to have both the renin-aldosterone ratio and the plasma aldosterone.
Yes, that's very important, because you'll have a patient that might go to a different lab. They might not want to stick with WVU labs. They find one that's closer to their house, and then you get this ratio, and it looks like I've seen these ratios be 50, 80, because they are seeing a renin level that's really low, and the plasma aldosterone level is only 10. So but when your denominator, because the renin, you have to remember, is on the denominator, if that's low, it'll automatically make your ratio skyrocketing high when your numerator is really anything above 1. So so that you got to be careful of that. And really, a lot of the literature states that primary hyperaldosteronism, you really have to think about it, really consider it when that aldosterone level is above 15. There's a gray zone when it's lower. And one of the things that I didn't mention that is important is low potassium will drop your aldosterone. So you have to fix that. You have to give them potassium and make sure that that is, as close to 4 as you can get it, and then test them for their aldosterone and renin levels, because that can flush out primary hyperaldo when it was being suppressed by the low potassium.
Okay. Yeah. And the other thing you mentioned about for the Cushing's disease, okay, you mentioned the dexamethasone suppression test is the best one. So the time between they take the tablet and get the lab drawn, is important, or?
Not necessarily. I think it's important to have several hours between when they take the medicine and when they get their lab drawn. You're looking for suppression. So what you're looking for is how much or the activity of the dexamethasone in their body, and that that depends on how well they absorb the medicine and the concentrations that it can reach in the bloodstream. So a lot of endocrinologists will test dexamethasone level. You can actually test the level within the bloodstream as well as the cortisol level, just to be sure that one, the patient took it, two, that it reached an adequate level in the bloodstream when you have the lab drawn. Um, it doesn't need to be 8 hours. It can be less than that if the patient took it later at night. But I try to make sure that most people take it about midnight and that they try to get the lab drawn before after 7, but before 9 a.m.
Okay. And is there any cutoff for that? And when you say the morning cortisol, it's going to be plasma cortisol or urine?
No, you want it to be plasma cortisol.
Okay. And is there any cutoff for that cortisol level that makes it normal, abnormal?
So the highest specificity and sensitivity, the highest is going to be 1.9. You want it to be less than that. If you see a level that's less than 1.9, you're guaranteed that, virtually guaranteed, of course, there's no absolutes, but you're virtually guaranteed for it to not be Cushing's or any sort of cortisol excess. If you see a level less than 5, that's pretty highly not going to be Cushing's either. You have to be more suspicious that it still could be. And there is the concepts of cyclical Cushing's and other things that could be reducing their cortisol levels and all that kind of stuff that can make you be more suspicious of it. Alcoholism can mimic Cushing's a lot too. So you have to be thorough in your evaluation. So yes, there are. The 1.9 is the easiest, but when you get above that, but they're less than 5, I would be suspicious that you need to do more testing. You need to be more thorough. What I like to do when I get sort of gray area results is another test that has very high sensitivity and specificity. That's a salivary cortisol level. Our saliva actually does have quite a bit of cortisol in there naturally, and it's actually pretty good because it's free cortisol. There are no protein molecules that bind up with that cortisol, CBG and the like, that would kind of interfere with our results. So you can get really good levels when you ask the patient to do a saliva-based cortisol. That's sort of has a caveat too. You need to get nighttime saliva cortisol. Our cortisol levels follow a circadian rhythm. It's diurnal. It increases in the morning time and then it drops as the day goes. We have our lowest cortisol levels of the day right at midnight, right around bedtime, 11 to midnight. So you want to test these people when it's supposed to be at the lowest level. Cortisol, our Cushing's will always have an elevated cortisol level throughout the day. So getting them to do their saliva tests at midnight and then handing it in the next day. If that's less than 50, you're looking for it to be undetectable. If that one is less than 50, some labs have it less than 100 micrograms, then you'll see that that's pretty reliable and that you can rule out Cushing's.
Okay. And the last thing is for the pheochromocytoma, you recommend the 24-hour urine metanephrine as the best test to rule in or rule out.
I do, really, because the incidence of pheo is low. Now, if you have a patient that has life-threatening symptoms, you don't want to delay diagnosis, and you would do the plasma, but you have to be sure that they're doing it correctly. And I would prefer them to be lying down, sort of position when they have the blood drawn. And if you call your lab before they go there and you make sure that they know that your patient's coming in and this is the way you want their test, they're pretty amenable to that. Though I have had no issues calling up my labs around here and asking them to do that special things when I ask them to order labs. It's one of those things that you're going to see a lot of low probability patients. And so urine testing is the best way to do that and to get the more accurate result. But if you have somebody that's really having symptoms and they're really severe and you're worried that, that it could cause a stroke, don't delay them for a 24-hour test. You want to send them right away and get plasma studies. And then plasma studies aren't going to be subtle. You know, they're not going to be just barely detectable. They're going to be outrageously high, and that would help you with your diagnosis.
Okay. Thank you so much. It's just that right now the trend I'm seeing is many of the adolescent, when they transition from peds to adult, when they come as a new patient, okay, of course they are obese and then they have high blood pressure and they are in their 20s, close to 20s, and then you think about ruling out the secondary causes. That is the most common thing that I face.
Yes. Yeah, and unfortunately, obesity is a strong activator for mineralocorticoid, and then it's one of those things that go along that cascade. So you have to be suspicious. You should test for it if you think that it's there, and you can get good results from proper screening. And it's nothing to discourage screening and evaluation. It's just that you have to know what you're looking at before you order that test. That's the most important thing. So in your individual that might be 20, 21 years old, that has high blood pressure, they're on a lot of medicines, they're obese, you know, you would want to just make sure that they're not on spironolactone and go ahead and test for aldosterone, and make sure that, you know, that their potassium levels are good too. So you want to do a basic metabolic panel as well as these other screening tests.
Thank you.
You're welcome.
Thank you for the great questions, Dr. Pollywall. Anyone else have any other thoughts, questions, or comments?
I love the lecture, Dr. Field. It was great. Thank you so much for participating in ECHO.
You're welcome. You're welcome. Thank you.
Thank you.
Any other thoughts, questions before I get into the announcements? Alrighty, well, thank you again, Dr. Field. This was awesome, and we have it recording, and we have a YouTube page that we're going to post it on as well. So I'm sure it'll reach a ton more providers. So we really appreciate it.
Thank you.
Only announcement that I have is that our next session will be on November 10th, and Hugh Quinn will be providing the didactic on coverage for outpatient diabetes care. So keep an eye out for that reminder, and we'll